people say heart disease, there's a lot of different buckets, but tonight talking about coronary disease. So the concerns are that you get buildup along the arteries of the heart. The heart is roughly the size of your fist. You have usually 3 to 4 main arteries wrapped right along the outside. Each of those giving out smaller branches to eventually feed that heart muscle. The two main issues with heart disease, you can have gradual narrowing of those vessels, causing a bottleneck, limiting blood flow to the heart muscle. That's when people get angina, chest tightness, pressure, those kind of chronic symptoms, usually with activity. The other more sudden onset episode is a heart attack. So what happens is those very small walls separating the cholesterol from the bloodstream, if those get eroded through, rip open, that's the sudden heart attack event. You form a sudden clot, the blood flow stops, and that's the heart attack that we don't want to see. So we've made huge progress in treatment since the 50s. So this is a graphic, and I know it's small for everyone in the back, but starting in the 50s, we didn't have a lot of tools. Over time, we have new treatments and trials learning all of our best options. You know, in the 1950s, Eisenhower laid in a hospital in Denver and just wrote out the heart attack. Lyndon Johnson was known to have heart disease, and that's why he made Heart Month official in the 60s. The first bypass, 1967. Aspirin proven effective in the 80s. Bare metal stents, which are stainless steel based, in the 80s as well. Statins, very important cholesterol medicines in the 80s. And now the newest stents are these drug-eluting stents that actually have a metal scaffolding to open the arteries, coated with a medication to help prevent re-narrowing of those vessels. So despite all those strong improvements, heart disease is still the #1 killer overall for the US. This is data from a couple of years ago, almost kind of outnumbering the next two causes combined. And I'm pretty sure this was published the day I landed back in Ohio. This is Mercer County is #1 in heart disease, so not what we're looking to achieve here. This was looking at numbers for kind of premature onset, working age adults having death from heart disease. So there are multiple things that we need to do, locally as well. Heart disease doesn't just fall out of the sky. So this is a recent study. 10 million patients were looked through a registry. When they look back to see who has heart disease, heart attacks, strokes, and heart failure, 99% of patients had one of the following 4 risk factors: high blood pressure, high cholesterol, diabetes, or smoking. So if we know what causes heart failure, if we identify it early enough, we can reduce those risk factors and hopefully mitigate risk and hopefully prevent episodes in the first place. On the left side of the screen, my left, your right, the American Heart Association put out a new framework called Life's Essential 8. 8 domains of health. If we work on those 8 key areas, we should be able to reduce future heart attack risk. So we're going to walk through those briefly. So the first one, eating better. There were some new dietary guidelines published that I think were pretty controversial in the cardiology realm. In general, our views are still that a Mediterranean diet or a plant-centered diet is going to be the best course of action to reduce the risk of heart disease. When we say Mediterranean diet, we're talking about whole grains, whole fruits, whole vegetables, chicken, fish, pretty sparing on things like red meat, things that are higher in saturated fat. I also stress plant-based protein, so nuts, legumes, lentils. High fiber is also good for lowering cholesterol, so those are all things that we'd like to strive for. The other thing we talk about a lot is a low sodium diet. Sodium's a key risk factor for high blood pressure. Again, one of our key risk factors for heart disease. Activity and exercise. The current recommendations stress trying to achieve 30 minutes of exercise 5 days a week of moderate intensity. For anyone who's doing a little higher intensity activity, you actually can shorten that time. People often ask, what should my heart rate be when I exercise? And that's not quite the right question because everyone's a little different. I tend to say if you are working out hard enough that you're getting a sweat, that seems adequate. If you're walking with someone and you can still speak in a full sentence, but maybe you pull that big breath between sentences, that's probably a good pace. If your hands are behind your back and you're strolling, that's probably a little too casual and doesn't quite count to your 150 minutes here. So, stopping smoking. This is the number one kind of risk factor that's modifiable that we can do to reduce heart disease. People think that smoking is very hard to quit, and we understand that. The average person has to quit 7 times before they're successful. But what we tell people is that when you quit smoking, your risk changes dramatically and quickly. Your risk of a heart attack or stroke or an event like this reduces by half within 1 month. It goes back to that of a non-smoker, within probably a year to 5 years. So as soon as you quit smoking, the benefits are pretty apparent. Each fewer cigarette is helpful for the lungs, but the heart isn't as forgiving. It's kind of all or none. 2 cigarettes is about as bad as 20. It's in the bloodstream. It's very inflammatory. So really getting down to a true zero, totally smoking cessation is what we want to achieve. Better sleep. For sleep, the main thing we talk about a lot is sleep apnea. So sleep apnea, I know it's common, people have heard of this. The main concerns are that when you're not breathing appropriately while asleep, it raises levels of inflammation. Inflammation is just, in general, injurious to the vessels, leads to more buildup on the arteries. Also, with that, you have higher rates of things like sleep apnea causing AFib, high blood pressure, especially tough to treat resistant high blood pressure, and also more diabetes. Healthy weight. This is much more in people's attention and kind of front and center nowadays, and every other commercial on TV is about an injection, I think. Our key metric is the body mass index. So essentially that's saying what should someone's ideal weight be based upon how tall they are, things like this. We also talk about the waist circumference. So people have often heard if you carry a lot of weight around your midsection, that's another risk factor for things like diabetes, fatty liver disease, and heart disease. With weight loss, obviously that's good for many aspects of your health. It's also gonna help joints, exercise. This is kind of a big multiplier for a lot of people. Again, there are those newer medications out that are injectables that help with weight loss. We get lots of questions about those. They are very safe and effective, but obviously talk to your doctors about what's right for you and what is appropriate. Lowering cholesterol. So cholesterol are these fatty compounds that are in all of our cells and animals. But the concern is that in excess amounts, they get into the walls of the blood vessels and build up those plaques in the first place. And so there's a little cartoon here. Again, I know it's small for the back, but showing gradual progression of heart disease and then showing where the plaque ruptures open and you form a clot, and that is the heart attack event. On the bottom, it talks about some different medications we have and also our goals for the cholesterol. So kind of for all comers through the door, we like the LDL, bad cholesterol, at least less than 100, even lower for some people depending on their own clinical history or other conditions they might have going on. We've got a lot of good medications to lower cholesterol. In the last 5 or 10 years, there's been a bit of a renaissance with some really new and effective medications as well. So cholesterol is a tough thing for a lot of people, but I think fortunately we have lots of good tools now. Controlling blood sugar. So within diabetes, the concern is that with elevated high sugars through the bloodstream, it is very inflammatory and kind of directly damages the blood vessel walls. That makes it more prone to the buildup of the cholesterol in the arteries. So again, along with smoking, these are things that just cause lots of inflammation of the lining of those vessels and a bit of a multiplier, kind of an accelerant for that whole process. And then the last thing here would be high blood pressure. So our goal blood pressure should be to get below 120/80. And sometimes people look at me pretty wide-eyed when I tell them that. The guidelines have changed in the last 10 or so years to gradually target lower goals. The main driver of this was a very large trial from 2015 with nearly 9,500 patients, half targeting 140 for that top number, half targeting 120. The group that targeted 120 had fewer heart attacks, fewer strokes, less congestive heart failure, fewer early signs of cognitive impairment or early dementia, and they lived longer. there's not many things that we do that check all those boxes. And so really getting blood pressure tightly controlled is one of the best things that we can do and pays off lots of dividends down the road. So for prevention, there are aspects of lifestyle, diet, and exercise we need to achieve. We need to identify risk factors early, and then whether through lifestyle or sometimes medications, help to reduce those risk factors to limit our risk of heart disease. I did put one quick slide on here about testing, if necessary, with your doctor. If someone is, we get this question a lot, with these new tests that are out. If someone's truly asymptomatic, one of the tests that's available now at Mercer Health is what's called a coronary calcium score. So this is a low-dose CT scan. And when we have those cholesterol plaques in the vessels, over time that becomes calcified and hardened. That's why they always called it hardening of the arteries back in the day. And we actually can see that light up bright white on someone's vessels, where we actually can see these calcified plaques. And so this is something that we can see heart disease before it's causing chest pain, symptoms, shortness of breath, as opposed to a stress test, which is going to be something that is looking to see what is the blood flow down the arteries to feed the heart muscle. That is typically reserved for someone who's actually having active symptoms of chest pain, tightness, shortness of breath, something that's getting our attention. So these are different tests and in many ways complementary, but obviously like any other test, it's gotta be the right thing for the right person. So I think with that, I'll toss it over to Craig.
All right, thank you, Dr. Brophy. As Dr. Kaur mentioned in our opening statements, I'm one of the emergency medicine physicians at Coldwater, and I have the privilege of taking care of all of you when you have the big one. I'll be there waiting for you. I'm going to spend the next 10 or 15 minutes just talking a little bit about a heart attack, what symptoms are of a heart attack, what you can expect when you arrive in the emergency department, and what our current treatment processes are. Dr. Brophy highlighted the essential 8 from the American Heart Association, okay, and most of those are modifiable risk factors. But unfortunately, there's also non-modifiable risk factors. I see a couple of people out here that I would label as elderly, a non-modifiable risk factor, males, genetics, family history. So in the end, even if we follow those 8 rules, we still will have some risk for coronary artery disease. And unfortunately, a plaque can rupture and suddenly we have that myocardial infarction. When does it become an emergency? When that plaque ruptures, all those platelets plug up that artery and suddenly we have decreased flow to the heart muscle and the heart muscle starts to die. You can see in this picture, when the clot forms, there's no flow past that and all the muscle beyond there starts to die. It lacks oxygen and oftentimes that is irreversible. Dr. Brophy commented on the progression of coronary artery disease. So you can have non-obstructive coronary artery disease where you have plaque buildup, but essentially you're asymptomatic. As that plaque continues to grow, you may develop some symptoms, what we term as angina. And then when that plaque ruptures, and again that vessel is plugged, that's when you have the heart attack, or what we term myocardial infarction. The average age of the first heart attack in a male is 66 years old. Average age for a female is 72 years old. So what exactly is a heart attack? Essentially is what happens is there's decreased blood flow to the muscle of the heart. Therefore, that muscle begins to lack oxygen and other nutrients carried by the blood, and it begins to die. That results from an atherosclerotic plaque that ruptures. Once that plaque ruptures, all of our platelets, white cells, and other cytokines and things that circulate in our body plug up that vessel. And our goal in the emergency department is try to open that up and get you to treatment where we can reperfuse the heart muscle. Time is tissue, okay? The longer that muscle is starved of oxygen, the greater tissue damage and the greater muscle death that occurs. What are some of the symptoms of a heart attack? Of course, everyone knows chest pain, okay? But it's not this noxious, terrible, stabbing pain. Most of the patients I see come into the emergency department having a heart attack, it's that smoldering tightness, heaviness across their chest, okay? Oftentimes, they can describe it as something sitting on their chest. If you Google it, it'll tell you an elephant sitting on your chest, okay? What it's not typically described as a sudden sharp. I had a twinge in my chest that lasted 2 seconds and it's gone. Or I turned my head and I had a sharp pain shoot through my chest. Typically, the chest pain of a myocardial infarction is very constant, and it's just that smoldering pressure type pain. It may radiate into your neck, may radiate into your arm. I see a lot of people come in with pain through the middle of their arm with associated chest pressure. Other symptoms of a heart attack would include nausea, that queasy feeling in your stomach, feeling like you're going to vomit. Frequently, people will complain of some shortness of breath. Not that they're suffocating, but they're air hungry. Just can't get a full breath. I just feel like I need another breath. Also, you may have some sweating, cold, clammy feeling, cold sweats. People complain of weakness and generalized fatigue. And occasionally that patient has that feeling of doom. Our body knows when something's wrong, and it creates this anxiety or this feeling of doom that something is different. When you experience these symptoms, that's when you need to come see me. Okay. Some of the non-classical symptoms of a heart attack would include heartburn. We all occasionally have heartburn, but we see lots of people come in and they think they're having some reflux or heartburn, that burning in the chest, or epigastric pain, just pain in the upper abdomen, common symptom in the elderly. Maybe a bubble in the chest. People come in, they just feel like there's a bubble underneath of there. Can also be symptoms of an MI. I just mentioned abdominal pain. Epigastric abdominal pain usually gets up right underneath the sternum. We'll see patients with dizziness and occasionally confusion as well. Males versus females, there are some different symptoms, but for the most part, from my experience, they're very similar. If anyone's going to have atypical symptoms, it's generally the diabetic female or the elderly female. And occasionally they'll just have some vague discomfort. Maybe they're sweaty and clammy, just feel weak, but not that classic chest heaviness that we expect to have with a heart attack. As I mentioned before, time is muscle. Okay, the longer that heart muscle is starved of oxygen, the more damage that occurs. And that can result in complications like ventricular aneurysms, ventricular rupture, valve rupture, arrhythmias. Okay, we all hear about the widowmaker, that sudden cardiac death. Okay, that's a lesion of your proximal LAD, one of the vessels Dr. Brophy just talked about. It's the highway, it's the Interstate 75 of your heart. Provides the majority of the blood flow to the heart. You can rupture a plaque and you have sudden death, you collapse. 71% of all out-of-hospital cardiac arrests occur in our own home. So you think about it, you're in home and your loved one, people you're living with, collapse. 71% of the time it's witnessed, and that's where we need to perform CPR. There's CPR classes all across the county, the hospital, etc. I encourage all of you to learn CPR, and if you don't know CPR and you witness something like this, still get on the chest, because something's better than nothing. And these days, you don't have to get down there and lock lips and blow in their mouth, okay? You just push on their chest. But the survival rate is double to triple if there's bystander CPR versus if there's no bystander CPR. So when you suddenly have that chest pain, you call 911, okay? You immediately go to the emergency department, okay? And what happens when you get there? It's a rapid triage and assessment. All hands on deck when somebody comes in with chest pain. The patient that showed up with poison ivy, I hate to tell you, go to the back of the line, all right? We get you back immediately. Our goal is to have an EKG within 10 minutes. 10 minutes of you come through our doors, we'll have the EKG. I've looked at it and I've determined, yes, this is a myocardial infarction or it is not. And I will tell you that last quarter at Mercer Health, we achieved 100% success rate with that, with every chest pain that came through the door. What do we look at? We're looking for ST elevation. I realize for many of you, this is a bunch of squiggly lines, but Dr. Brophy, Dr. Boley, and myself went to school for a really long time to learn how to read these, okay? This is an LAD lesion. This is the widowmaker that we all hear about, okay? You can see the ST elevation here in the precordial leads, okay? That indicates significant injury to the heart and infarction. We now have the ability to get these EKGs by EMS in the field at your homes. When you call 911, EMS comes, they do the EKG via Wi-Fi and the internet technology. They send it to me in the emergency department, where I can then start to help with the treatment and give suggestions while en route to the ED. What's even better about that is I'm able to activate an aircraft or helicopter and already have that en route to the hospital while you're still at your home getting packaged to come to the hospital. So we save a lot of time, turnaround time, because in the end, it's all about reperfusion, getting that vessel open. And definitive treatment is a cardiac catheterization, in which we need to get you transferred to a facility to get your heart cath. You can expect to get a chest x-ray. We generally do a chest x-ray really looking for alternate diagnoses, because not every chest pain is a heart attack. Maybe it's a collapsed lung. Maybe it's a mass in the lung. Maybe it's a bunch of fluid around lung or pneumonia. But we always do a chest x-ray to look for alternate symptoms as well. Alternate diagnoses. And you can also expect to get some lab work done. We're drawing blood work to look specifically at an enzyme called troponin. Troponin is a protein that's released from dying heart muscle cells. So when those cells are damaged, they release this so we can measure it in our lab. So those heart attacks that aren't necessarily picked up on the EKG, this troponin will diagnose. As far as the treatment goes, one of the first things we're going to do is give you aspirin. You'll get 4-baby aspirin. And if there's one thing that I can educate all of you on, if you develop chest pain and you have other symptoms of heart attack and you're coming to the emergency department, if there's one thing you can do at home is chew 4-baby aspirin before you leave. It's the one drug that time and time again has been shown to decrease mortality associated with a heart attack. We do 4-baby aspirin. We ask you to chew them. Why? Because it increases the surface area in your abdomen, so you absorb it faster. This isn't the time to take the enteric-coated aspirin. And trust me, more is not better either. Don't take the whole bottle, because then we deal with a GI bleed, all right? Just take your 4-baby aspirin. You might get oxygen while you're in the ED. There's specific parameters now that dictate when we use oxygen and when we don't. Actually, it's been shown that too much oxygen can be as harmful as not enough oxygen. We may give you nitroglycerin. Okay, nitroglycerin dilates the coronary arteries, oftentimes helps with the pain associated with a heart attack. There are some contraindications, so not everyone gets nitroglycerin. We always put patients on the blood thinner. We either do this through an IV blood thinner or through a pill form, but we'll put you on some type of blood thinner to try to prevent all them platelets and things from sticking together and plugging up that vessel. And lastly, we may administer some pain medication, okay? Me personally, I love to use fentanyl. I know it gets a bad rap because of all the abuse in the public, but there's a lot of studies that have come out recently that show that fentanyl decreases the sympathetic response that occurs with a heart attack. So our body knows something's wrong. It starts secreting all these epinephrines, which does what? Increases your blood pressure. There's a big cascade of events, and fentanyl blunts that. So it's been shown to improve outcomes in the setting of a heart attack, and it helps your pain. In the end, the definitive treatment is opening that vessel. And through the ED, we have basically 2 pathways we go. And a lot of it depends on timing. We can look at using a clot-busting medication, what we call fibrinolysis or thrombolysis, or we can refer you or transfer you for an emergent cardiac catheterization, or what we call PCI, percutaneous coronary intervention. If the time from the first medical contact to the time you can be on that cath lab table, getting that vessel opened up is less than 120 minutes or 2 hours, we're going to try to send you for a heart cath. And that is really the preferred treatment. Occasionally, though, we can't do that. In rural Ohio, we can't always get you to a cath lab within that time frame because of weather, lack of access to transport, many different reasons. So occasionally we have to use fibrinolysis, in which we administer a medication that helps dissolve that clot. There's a lot of contraindications to its use, so it's used very infrequently. You have to imagine we administer this medication to dissolve the clot. It's like a blood thinner, but it doesn't just go to the clot. It goes everywhere else also. So there's risk of GI bleeding, maybe bleeding in the bladder, bleeding in the brain, etc. They're low, but for that reason, we really prefer to go the route of heart catheterization. I've got 4 hospitals listed up here that we have transfer agreements at Mercer Health, where when a patient comes with a myocardial infarction, we know that we have automatic acceptance, so it expedites our process and transfer. Okay, I don't have to make the phone calls to them. They automatically accept you. We can call for the helicopter or our ground transport. Okay, it's really improved our times as far as door in and door out. This is an example of the clot busting medication. You can see the green here is the medication dissolving the clot. Think of this as your bathroom sink. Everyone's had the bathroom sink that's plugged up. And what do? You go to Walmart, you buy the bottle of Drano, you dump it in there. You wait 30 minutes, you turn your water on, and shazam, the water's flowing again. It's the same thing. It just dissolves the clot. When we look at heart catheterization, There's several different things that can be done. One, balloon angioplasty. The other would be stent placement. Everyone's probably most familiar with stents because that's what's most commonly done now. Essentially, a catheter goes in, goes up into that blocked coronary artery. That catheter has a balloon on the end that can be inflated, and around that balloon is a stent. So when that balloon inflates, it deploys the stent to the walls of the vessel. The balloon then is deflated, and that stent stays open and allows continued blood flow to the heart or restores the blood flow. In angioplasty, very similar. The catheter goes in with the balloon. We blow up the balloon and kind of squish all that plaque out to the edge of the vessel and then deflate the balloon and remove the catheter. This is a great slide that I borrowed from Dr. Brophy. Okay, it shows the access for your heart catheterization. Most commonly, it's in the groin or the wrist. These days, they like to go through the wrist, depending on your anatomy. But the catheter goes up into the vessel. We squirt some dye in where you can see the vessels, identify the blockage through a series of x-rays, and then they can deploy that stent or do the angioplasty. Mercer Health became acute heart attack ready certified in 2021. Okay, this is a rigorous certification that helped us more rapidly identify patients with myocardial infarction and provide more efficient care. There's only 34 hospitals in the entire United States that are acute heart attack ready certified. Mercer Health is the only hospital in the state of Ohio. It requires a lot of work. Credit to one of your local folks, Jody Tebby. I'm not sure if she's here tonight, but she oversees this program for us. Does a phenomenal job. But we've really seen a change in our care over the past 4 years because of this. I'm going to comment on a few things here real quickly just about the heart attack ready program. We've got a lot of new technology because of it. One thing is something called a Pulsera app, which is really cool because I can take my phone. You come in with a heart attack, I have your EKG, I can take a picture of it on my phone through this app and I hit send. It goes to the cardiologist at, let's say we're going to go to Upper Valley Medical Center. He gets a text, ding, he opens it up, looks at it, says, yep, that's an MI. He hits accept. It sends a page out to everyone in his cath lab and to me that yes, this is a heart attack, we'll be ready for you in 30 minutes. I cannot possibly pick up a phone and dial the number and explain that EKG faster than when he can look at that picture. But that's some of the new technology that we have, thanks to the acute heart attack ready program that we've been utilizing to help get our patients to the cath lab faster. Our average EKG time from the time of diagnosis 2025 was 12 minutes. I just got that data last week. I had to brag a little bit about it. So we're ready for you when you have the big one, when you have the heart attack, because we all know that we're still going to eat ribeyes. We're still going to have a cigar every now and again. Might even have a few other of those bad habits. But we'll be ready for you in the ER. So when PCI is not an option, we look at bypass medical treatment. I'm going to hand this over to Dr. Boley. He's going to talk a little bit about that as well as what you can expect after you have a heart attack.
So this aspect of the presentation is kind of dear to my heart because it's the reason why I went into cardiology. I found when I was trying to figure out what field I was going to go into, every field has this exciting aspect. And we've just heard from Craig, the acute MI is the exciting aspect of cardiology. But it's the chronic conditions that we have to deal with day in and day out is what you've really got to decide you like, because that's what you're going to be dealing with after the acute event. And that's why I went into cardiology, and that's what we'll talk a little bit now. So first thing we'll talk about is when you can't get ballooned, you get your cath done, and you find out we can't fix you, you're going to need something more than just a balloon or stent. And your options is, at that point, is either going to be bypass surgery or whether you're going to be treated medically. And the reason why bypass surgery happens is because you've got multivessel disease, bad blockages to all three arteries. Survival statistics are better for bypass surgery with people who have triple vessel disease where their heart function is not normal, and people with diabetes. So in that situation, stenting is not an option. You'll be headed towards bypass surgery. And sometimes that doesn't happen immediately unless you're totally unstable. I call it the Bill Clinton phenomenon. If you remember when Bill had his heart attack, he was diagnosed with it, but then there was a delay in 3 or 4 days or 5 days before he had bypass surgery, and that's because of all the medicines he got in the ER to try to get him ready for the balloon and stent that he couldn't get, and he had to let that medicine wash out of his system before he underwent his bypass surgery. Sometimes bypass surgery is not an option, and you've got significant disease in all vessels. The vessels are very tiny and small. They won't accept grafts, and your best treatment option is just with medical management. And those you find a lot in people with diabetes. They have smaller sized vessels. You can bypass anything. The problems are if the vessel caliber is not big enough, the graft's not going to stay open. So when people get bypassed, when they're wheeling them out of the OR, sometimes they lose their grafts right away, and they don't know that until years down the road. But that's why sometimes bypass surgery is not an option for those people, and they do better if they just get treated with medicines. And it's pretty amazing when you see some of these films on people that haven't had bypass surgery that's had their own nature's bypasses built just from stimulating growth on their own. So this is just kind of talking about bypass surgery. So key thing with bypass surgery is if you do get bypass, if you can, try to get as much artery bypass as you can. So you've got arteries, and what they typically will use is your chest wall artery, your left internal mammary artery, and they'll tie that into the main artery that runs down the front of your heart. You've got other arteries that they can use. They can use their right chest wall. They just got to make sure you got enough blood supply to keep your sternum to survive. Sometimes they'll take arteries out of your arm, but the key thing is using as much artery as you can, because it's bypassing an artery to an artery rather than bypassing a vein to an artery. And the survival of a good artery is much longer than what it is with a vein. Next thing to kind of talk about the rehab is cardiac rehab. So people that have had their heart attack, they've either had their balloon or stent, or they couldn't get stented and they had to get bypass surgery, or for the people that just have to be treated medically, cardiac rehab's a key component in the recovery. One of the comments I read was, cardiac rehab doesn't change your past, but can help improve your heart's future. And I think that is kind of the motto or the credence for cardiac rehab. And the way that it does is a approach where it is both education, exercise, and I think a key component at the end is the overall camaraderie, emotional support that you get with other people just like you that are going through the heart attack and the recovery after the heart attack. So the exercise component, supervised exercise, you're on a monitor, and I've had a lot of things picked up that otherwise wouldn't have been picked up if the patient hadn't elected to do cardiac rehab. That includes rhythm disturbances, heart block, so things that if they had elected not to do that would never have gotten picked up and would clearly have affected their outcome and recovery. The educational aspect of things, I think you just don't need to say anymore. Everybody can stand to learn something. And cardiac rehab gives us a chance to learn things that we didn't know was important in our recovery from the heart attack and for improved survival long term. And then the last thing is just that emotional aspect of things that I think is important for to know that you're not alone. You've got other people just like you that's going through this, and that camaraderie. You'll see a lot. People will go into the maintenance program at the cardiac rehab programs just because of seeing people that had been through it, and it's a family event now. This gets down to kind of the long-term treatment and recovery for people post-heart attacks. And there are certain things that medicines that you should be on, and this is where it becomes a constant battle when you come back to see us in the office, because you get sent home from your heart attack or your bypass surgery and you've got 7 different meds, and you walked into the hospital with one, and doc, how soon can I get off of these meds? And so there's certain things that you feel that is very important. Craig talked about aspirin. I think that's definitely what you want long-term. People that have had stents are going to need to be on another aspirin product, and that'll either be Plavix or Brilinta or Prasugrel or Effient. And I think of those as just, they affect the stickiness of your blood. They don't thin it out. They're not blood thinners, but they affect the stickiness so it doesn't adhere to the walls. But if you get a stent and it's drug-coated, you're going to need to be on it a year, and you don't want to stop it before the year's up unless you have some type of appropriate coverage. So after a year, it depends on what type of cardiologist you are, whether you'll continue it or not. If you're an interventional cardiologist, you'll say you need to be on it lifetime. If you're the medicine cardiologist that deals with the GI bleeds and the bruising that everybody complains of, you'll probably stop it after a year. Certain circumstances, you don't necessarily, if they've had re-stenting or a stent within a stent, if they're higher risk for that complication, then we'll tend to keep it going on longer than the year. Beta blockers, and that's kind of one of the other big key things that we like post-MI, improves survival, cuts down on rhythm disturbances that you can have after your heart attack and in your recovery phase. Great treatment for blood pressure, keeps your blood pressure and your heart rate down. So it's one of those key things that you'll want to keep in your system. Cholesterol meds, that's the big thing that is stressed, is to get your cholesterol. Once you've been diagnosed with coronary disease, whether it be with your heart attack, whether it be with your calcium score, your LDL goal drops now down to 70. And so you really want to get your cholesterol low. If you've had a heart attack, you'll probably end up either on 40 or 80 of Lipitor, just based on the recent studies. And the key thing is following it long term. I tend to tell people to try to take coenzyme Q10, 100 milligrams with it to try to cut down on. There are clearly some people that can't tolerate statins, and fortunately there are other options out there, some injectables, Repatha and Praluent, to help lower your cholesterol. But the key thing is to try to get the cholesterol down and halt the progression of coronary disease. And the other important feature in dropping your cholesterol that low is to stabilizing plaque, so you're not back in the ER seeing Craig another time. And then having nitroglycerin available, that's always important. Things that, the way they work is by dilating your blood vessels. So I usually try to have anybody that's had a heart attack or a bypass surgery have nitroglycerin available. And my motto is usually, I'd rather you have it and not need it than need it and not have it. And then additional meds above and beyond that depends on whether you've had, how extensively damaged your heart muscle was from your heart attack. If your pump's not normal, then you'll be on some type of medicine to help improve your heart pumping function, an ACE inhibitor, an angiotensin receptor blocker, a class of meds that help when the heart muscle is weaker. Those are kind of the main ones that I tend to see. If people have the medical management people, or even the people that have had bypass surgery with stents, or if they had chronic angina or chest discomfort afterwards, then you'll see some chronic nitrates, or another medicine you'll see is Renexa that we use to try to help improve the angina. And then secondary prevention, and that's just pretty much what we've already went through this evening, to try to help prevent you from coming back and visiting us more than what you want. I guess at this point I'll kind of stop and see if anybody's got questions.
You used to have at the hospital of cardiac wellness after you had a heart attack. Do you still do that?
Yeah, there's a wellness program. So if you go through cardiac rehab and then you decide you want to stay on, there's a cardiac wellness program where it's non-supervised. The staff's still there, they answer questions, but you're not on a monitoring. So they do have the wellness program.
Stents plug up again? When you have stents put in, can it still cause another blood clot there too?
Yeah, sure can. So with stents, the big thing is making sure you don't miss the medicines. So now I'm starting to date myself, but I was back in the air when stents first came out, and I was actually a fellow down at Duke. And at that time, we had stents, and we really didn't know how the best way to treat people with stents. So at that point, we didn't know it was best to be simple and deal with aspirin and Plavix and call it a day. Back in those times, we didn't know that. So we thought, oh, they're going to cut the stem off. You got to kick them on heparin or a blood thinner until they get thinned out with Coumadin or warfarin. We didn't have all the other newer stuff. And we found that actually we were hurting people by doing that. So I can remember when I was a fellow, a lady that we were transfusing because she was constantly bleeding because she had a fresh stent and you can't stop it. The theory was you can't stop the blood thinners because you're going to cut the stent off. And we actually proved it one night that was the right thing you do is to stop the heparin, because I kept calling the attending every hour until he allowed me to stop the heparin. She lived and she survived, and then shortly thereafter it came out that the best thing to do is aspirin and Plavix and call it a day. But getting back to putting stents in, when stents first came out, Plavix was pricey. And so you put the stents in, and if people didn't take the medicines, they would come back and would close the stent off acutely. So that's why initially when we started putting stents in, we always had these free copay cards for Plavix. And it was for 30 days of Plavix. And we knew at least for 30 days they wouldn't be coming back to see you. But after the 30 days, and that's why if there was a concern that they weren't going to be able to afford it, we wouldn't put drug-coated stents in. These people would just put bare metal stents where you can get by with 30 days and call it that. The risk of re-narrowing is higher in the bare metal than what it is in the drug coat. So getting back to your answer, can the stents close? They can close if you don't take your meds. They can even close if you do take your meds. The people with diabetes are more likely to re-narrow or restenosis stent. And a lot of it depends on the stent size. The smaller the size, the more the risk for re-narrowing stents. And that's why if this vessel is too small, you're probably better off not sticking in a piece of metal that's coated with material. Just let you build your own nature's bypasses to that vessel.
Along those lines, I've actually never put in the bare metal set before because those were out of fashion by the time I was there. Oh, the new stents are called drug-eluting stents. So, like Jerry said, even on aspirin and your approved regimen, the stents can close up. The stents are essentially a foreign body in the vessel, and it could be irritating. So some people are more prone to this, where essentially they'll start to scar down and re-narrow over the stent scaffolding. These drug-coated stents, they're essentially coated with medicine that's an anti-inflammatory, almost like a chemotherapy, where it's going to try to slow down that progression and that scar tissue from re-narrowing the vessel. So anymore, if anyone gets a stent, it is essentially universally going to be a drug-coated stent. These stents are very effective and safe. There are some new data about stopping that second blood thinner a little earlier and just doing aspirin by itself sooner because of that bleeding concern. But no, people do get re-narrowed stents. People have gotten stents within stents sometimes, but we like to avoid that if we can. So, I have the question.
Is there a maximum number of stents one can receive?
Total or in one location? So I'll be here so Jerry's answer is there's not a mass number of stents, I guess, in theory, but hopefully we keep it to one. I have seen 3 layers of stents in a single location. Beyond that, we don't like to put another layer in, and so we used to do some unique things like use radiation called brachytherapy, where it's a radiation delivered during the cath lab. But that's exotic and not done a lot of places. So, yeah, once.
I guess the other thing is just remember, if you're putting the stents in vessels, you want to make sure that you're not keeping yourself from in the future potentially getting bypass surgery, because you got to have a piece of free vessel that doesn't have a stent in it that you're going to tie a bypass graft into. So you can get stented, but you also don't want to get stented too much if the ultimate outcome is going to be you're going to need to be bypassed.
Along those lines, there was a really good cardiologist, Sunil Rao, who was also at Duke back in the day and now is at New York. They did some research showing that when you get stents, you fix that area, but it might kind of kick the hornet's nest and make the other disease accelerate and progress a little faster. And so the key thing is we want to stent only what's necessary and nothing extra. So during the heart attack, they're going to fix that culprit. They're going to fix things that are critically narrowed, like 70% blocked and worse. If there's something that's 40 or 50% blocked, we don't touch that. People get nervous about that. We don't want to fix things, haphazardly. So only fix what's necessary and leave the rest alone. So, yes.
So I have a comment and a question. So the comment is, even if you are not CPR trained, just get, as after Du's mentioned, just get on the chest and do compressions. And in Mercer County, if you call 911, and actually most counties, they, our dispatchers are medically trained. So they can talk you through what to do until an EMS provider can get there. So don't be afraid and do it. It helps all of us that are in EMS to ultimately save your lives and help them save lives in the not. So that's the comment. The question is, there's a lot of literature out there that says there's a benefit to coenzyme Q10 or CoQ10, especially if you're on a statin. What are your feelings about that? All of it.
Yes, sir. I would say most of the literature on supplements is tough because they're not doing large trials to really find definitive answers sometimes. There are smaller studies that look like CoQ10 for some people is helpful to reduce side effects like muscle aches and things like that. If I have patients who are taking that with their cholesterol medicine, I think it's fine. I tell them to keep taking it. If someone's not having trouble and you're not on it, I don't tell them to take an extra pill because I'm sympathetic. But in general, not harmful for some people, very helpful. One of my guys I think is really great in Cleveland. One of my classmates saw him buying it by the large bottle at Costco, so there must be something to it. I guess that I already.
Yeah, I usually tell patients a very similar type comment. I think if you feel like it gives you benefit, take it. If you don't. It's kind of like, it's like glucosamine can draw. Some people are firm believers that it helps with their arthritis, and other people don't get benefit. So I say, if it helps you, take it. If it doesn't help you, don't stay on it.
And on Dr. Boley, it used to be years ago, they told you to take a baby aspirin a day and keep the heart attack away. And I was on it to my daughter, which is retired now, took me off of it and says you don't need it. Maybe that's a good anymore or not good.
Yeah, I grew up in the day where if you were on a deserted island and you only had one thing to take with you, you'd take your baby aspirin. When they started saying, "Oh, you don't be your aspirin," I'm like, "There's got to be more data than that." They told me that in history. So I still believe in that. I think the only people you have to be really cautious about is the people that have bad gastrointestinal bleeding issues. Then you got to weigh the risk versus the benefits.
So my view on this, I'm a little more conservative with aspirin. So 3 studies came out all within quick succession and within about a year's time. Someone has stents, strokes, bypass, anything like that. I like this talk, sounding aspirin. If someone is older, over the age of 80, never had any issues before, probably not worth it because of the fall risk and bleeding risk. If someone's super young and no risk factors, probably no real upside there. The 2 groups I do recommend it in without having stents or bypass would be folks who have diabetes, and that trial probably was a net benefit to aspirin. And then for patients who have the coronary calcium scoring done, the more recent studies say when your score is over 100, probably aspirin's beneficial in that population. When you get lower risk than that, you're probably not doing a lot of benefit versus the bleeding trend off. So my answer is a little nuanced, but I don't recommend it routinely for young, healthy people.
I hope. I something that's always kind of bothered me is that we have a lot of prevention, for mammograms and colonoscopies. Heart disease is still number one cause of death. It's leave in the country. In a perfect world, what would you see as our screening for the general population?
I'm biased. I think the coronary calcium scores are super helpful. They are not covered by insurance because of some things 25 years ago with insurance, essentially. But I think they're a very good way to look at the arteries before buildup. Prior to just the CT calcium scores, we had the vascular screening, which I think is okay as well. The American Society of Preventive Cardiology does endorse things like calcium score to try to catch it early because, again, we can catch it when it's a 30% blockage and not let it grow. All we have to do is spike to a draw. We don't need to wait for the big one and meeting Dr. Dews if we can help it. So.
Yeah, I would tend to agree with those comments. I think, I tend to view the calcium scores. It gives you an answer. I always tell people when you get a test, always know what you want to have answered by. And the question is, do you have any evidence of atherosclerosis? If that's your question, then get the calcium score. And then I usually tell people if your score is anything but 0, you now have the diagnosis of coronary disease. You need to modify all your risk factors. You need to drop your cholesterol down to 70. And then I usually do some type of screening test afterwards just to make sure that whatever your calcium score is, that it's not significant. Yeah.
Along with the calcium score. So if you I had an initial one done, so you said you do screening afterwards, or could I repeat a calcium score, say 5 years later, 10 years later?
Yeah, I mean, that's a good question. Personally, I use it, as I said, your score is 0, anything but 0. If your score goes higher, I'm going to tell you the same thing that I told you before, modify all your risk factors, do everything that you can. So I typically don't recommend repeating it unless you like the number. I mean, it's what people get into, but I think that makes the diagnosis. The calcium score gives you the diagnosis, and then after that, it's monitoring for symptoms. And if you develop symptoms, then that's where other testing comes into play and to see if that's significant or not.
I think that's pretty true. I think if it's 0, the current society guidelines would say repeat it in 5 to 7 years if you want to continue screening. If it's positive, I agree that it's kind of binary. If it's positive, and you should do everything for risk factors. When it's very high, then I don't see a need in repeating it because we know the story. We need to just double down on everything we're doing. When it's mild, I think sometimes it's helpful to repeat it down the road because, again, if we eclipse some thresholds in our mind, if we get over a score of 100 or over 300, would I add aspirin over 100? Would I intensify the cholesterol lowering if your score was 500 rather than 200? So sometimes it's useful, I think, to see that in the future, but it depends on the situation a little bit.
Is there any advantage to having a calcium CT scan done after they have bypass surgery or 4 or 5 years down the line?
No,
Really?
no, because the bypass pulls the answer. You had too much buildup on the arteries. So this scan is strictly for asymptomatic patients in a what we call primary prevention setting. So we want to catch it before the episode. If you've already had an episode, even now, once in a while, the miss people who get through the screening filter and they've already got a stent, and I look at the CT scan and it lights up real bright. Like, well, they didn't need the scan, and I'm sorry that they had it done, but really just for preventing in the first place. So yeah, after bypass wouldn't necessarily be required or indicated.
I got a question. So if you have a history of heart disease in the family, like I do, would you recommend your children doing it? I know that with this heart scan, 40 is your baseline. Is that correct?
So again, it's a screening test. I don't really put too much emphasis, but in general, if you're gonna have buildup on the arteries and it's gonna calcify, it takes time. So even if someone has cholesterol buildup and they're 30, it might not be long enough to actually have that cholesterol harden and calcify and light up on the scan anyway. So when I think we'll do them, really young, I don't think that's super useful or high yield. So typically we say if someone's interested in it, family history or whatever, I would say males 40 and above, and women probably more like 45 above. With caveats, if there's strong family history, if something happened in a parent 45, and maybe we, scale back and start a little bit earlier, but that would be kind of an individualized discussion.
This is about AFib. You hear a lot of people having AFib, and I've heard of heart ablations for AFib, or medication, or even a Watchman for an AFib. What about all that stuff?
I'll love you that.
So AFib is separate from blockages heart disease. For AFib, what's going to happen is that typically in the top left chamber of the heart up here is where AFib usually comes out of. So I tell folks, instead of the top squeezing effectively for a normal heartbeat, and the bottom should listen, so kind of top and bottom in sync. AFib, the top's just doing this. And so the issues with that are you can feel crummy because your heart's out of rhythm, but also the blood's not being ejected forward effectively. And so the blood can swirl and pool and form clots. And so blood thinners help to reduce risk of stroke. The Watchman device is a device to help reduce risk of stroke for folks who don't tolerate blood thinners. They're kicking us out. And then an ablation is a procedure different than a heart cath, but they go in through the blood vessels to get up to where the AFib is coming from, and they essentially are going to scar over that short circuit to get rid of AFib.
Talk to us about prevention.
So just to repeat your question, I'm not sure that everyone heard. You're asking what can the family members contribute as far as the history when someone comes to the ED that would be important to us? Is that correct? Yeah. So great question. So most importantly is the past medical history. And essentially I'm looking at identifying risk factors. Where's their risk for a heart attack? Do they have history of hypertension, hyperlipidemia, diabetes, tobacco abuse, etc.? Okay. Have they had any prior coronary artery disease? Have they had previous heart catheterization or past stress testing? Every patient with chest pain, I ask those two questions. Have you ever had a stress test? Have you ever had a heart catheterization? Now commonly I'll even ask them, have you ever had any screenings on like coronary calcium scoring? Okay. Because in the ED, I'm trying to put all the pieces of the puzzle together and get as much information as possible to determine someone's risk, okay, for the heart attack. And then, of course, all the diagnostic information, EKG, troponins, and things like that. Medications are very important because, of course, there's always risk of drug-drug interactions, okay? And we want to know what medications they're on at home. Allergies, of course, we want to avoid certain medications where they may have an allergy. But really any contributing history as far as their past cardiac history, and then there's meds, allergies, and the events leading up to that, to why they're in the ED. So, for example, if someone comes in, their cardiac arrest and get return of spontaneous circulation, we have that resuscitated patient. That's when I come in and I sit down and I want to know exactly what happened. If this started several days ago, if this started several hours ago, all the events that led up to that moment of coming into the ED. Does that answer your question? Or, yeah, it's been specific. Or go ahead.
How much use of the MyChart information that do you have as a doctor available to you right away?
So, I guess to clarify, you have MyChart, which is something that all of you have access to, everyone can see. MyChart is kind of a part of what I call the medical health record, okay? Or at Mercer, we use something called EPIC. So the electronic health record is extremely valuable to me because if you've been, and let's say Miami Valley Hospital and had a heart catheterization, I can look up those results and I can see them at Mercer. Okay. If you've had testing done in another state now, oftentimes I can see those results. And that's very helpful for us. Okay. The MyChart itself is what all of you have access to, which is a little bit different than what I utilize in the ED. I'm using the electronic health record where I basically have everything. MyChart is a little bit limited as far as what you see, and it's of course specific to you.